Now, let's move to that PCP perspective. How do you find out when one of your patients is admitted to the hospital? Well, mostly we get really good information from hospitals that we're affiliated with. If our medical group is affiliated and does a majority of admissions to a specific hospital, and we have electronic health record compatibility between the facility and the clinic, we're highly likely to get information that the patient's been admitted and or discharged. How do you find out when your patient is discharged? Well, generally we receive a discharge summary, and sometimes the patient contacts us. So we're starting to see more variation, less of a strong focus around how that's going to happen, a lot more variety. Who receives the information? Primarily the clinic's medical records people. And a lot less likely will you see the care manager or the actual PCP be notified. Do you call the patient within a certain time frame? You as the PCP, as the clinic. If we know that the patient has been discharged, well, certainly. And when will that happen? Well, if we know, probably within 3 to 5 days of discharge. Do you have a standard process for medication reconciliation? You betcha. But I neglected to say, it's not necessarily a standard process that's been described. It is, well, usually we do it at the patient visit. So, which was an interesting anecdote, I thought. We do medication reconciliation, but it's really at the time of the patient visit when the physician and or his staff following that patient will initiate the dialogue around that issue. Can you accommodate the need for home visits to assess the patient's condition? Yep. Yeah, we do for the most part. The discharge planner in the clinic or the discharge planner from the hospital may in fact initiate that. And we have the capability to initiate home health from our clinic. And there's the rare physician who does home visits. Dr. Welby is yet alive and well. And do you track admissions or readmissions? Well, for the most part, no. And I would suggest that it goes back to the inability of that clinic to be able to track those patients because they're not receiving the information from the discharging facility to begin with, unless they're wired to them. So, what's the most frustrating for you as a PCP? Well, to some degree, family expectations. Lack of coordination, lack of available information and communication with the discharging hospitalist, not having the discharge summary at the visit. Having been a CEO receiving patients from acute care facilities in the metropolitan area, I would add my own testimony that the most difficult part of managing patients who are still significantly ill, coming out of critical care units, is the lack of a discharge summary for the admitting physician in the receiving facility. They just don't know. Nursing home discharges lack of information on the patient. Just the lack of communication, not even knowing of the admission or discharge. Lack of medication reconciliation at the discharging side, so that what happens is the patient receives, the PCP receives the list of medications the patient is discharged with. They include medications the patient was on previous to their admission. The list is long. It hasn't been reconciled. And it's incomplete coming to the receiving facility. What's the most difficult issue when your patient is discharged? Patient doesn't qualify for the SNF but needs it. Missing information, missing discharge summaries, communication with discharge planners, making sure pending issues are being followed up. Specialists not getting post-discharge information to the PCP. Again, it's just the inability to kind of get your hands around information that's just flying all over the place. And lastly, the long-term care facilities. When you admit a patient from a hospital, is the information you receive adequate to initiate and maintain care? Usually, but not always. Is there information that's not being sent that would be beneficial to you? Well, gosh, actually we had access to that pipeline of electronic medical record information, so the Epic PC Anywhere component, the ability to actually view that patient's inpatient records, that would be splendid. Even just having the physician and nursing notes available to us. and some kind of behavioral issues documentation. As you all know, so many patients going into long-term care facilities are at risk for behavioral issues, lots of associated with the lack of medication reconciliation that they may receive. Do you receive a prompt discharge summary? Well, about 60% of the time we do. So good. At least of the 5 facilities that responded, not doing too bad. What's the most challenging or frustrating issue you face? Validating the information set. So often, it's a Xerox pile of information that shows up, maybe shows up with the patient, maybe shows up later, maybe only shows up after multiple calls from the facility to the discharging, from the hospital. And then you have an admitting physician who's got 5 admits that he's sitting on, trying to go through this information, not knowing if it's valid or not. Obtaining ordered medications on the weekend, high insurance copays, just the basic issues associated with trying to settle a patient in to the long-term care facility environment. Do you receive contact information for the patient's PCP? Yeah, pretty much all the time. Does the PCP respond when you contact them? Well, no. Of the 5 facilities that responded, in fact, we found that none of them did. Perhaps it's because they don't actually receive any information that their patient is in your facility. I know I'm kind of beating the dead horse, but you can see the point. Do you have a standard process for reevaluating a patient? Pretty much the same, reevaluating a patient that's being readmitted to your long-term care facility that's bounced back to an inpatient facility from yours. Yeah, pretty much using the same, we kind of treat them as a new admission for the most part. Is the process effective? Well, the process is effective if the patient and family is willing to follow the plan. So we talk about patient compliance. Caregiver compliance is a real important part of the issue. One facility actually does home visits if they have concerns. We routinely do home visits prior to patient discharge. We have a standard discharge planning process. Everybody did. What's the most difficult or frustrating issue? Lack of engaged family, friends, neighbors, any kind of a support system for the patient that's being discharged from the long-term care facility, and the lack of plan coverage for follow-up post-discharge. That's the survey. I found it interesting. And I found it interesting for the obvious reasons that one of the things that we have an opportunity to work on as we move forward looking at ways to reduce readmissions from a variety of different perspectives across the state is to begin to frame the question. What can we do? A major intent of today, of you all coming here today. So, it appears I'm real close to being on time. You'll tell my wife that? I'd like to explain to you what I'd like to have you do next. You will find in the breakout section of your binder, aptly labeled, directions for breakout session number 1. What I would like you to do is take the opportunity to have a facilitated discussion that addresses the 3 questions that are listed there. The goal is that you will take about, looks like I've given you about 30 minutes to have that discussion. And to begin to describe what you see as the common barriers from your professional perspective and occasionally your personal perspective as we move through the transitional environment. And your facilitator will help you with that. The steering committee, CHF-COPD steering committee has graciously granted their facilitation skills, and we have made an effort to plant a steering committee member at each table. I've noticed, however, that there are a few tables that are sparsely occupied. I think in the best interest of the people that are, there are only a couple. If you take the opportunity to join a table that only has 4 or 5 people in it, this would be the time to do that. And the facilitators, if there is a table that does not have a facilitator and a table that might have 2 facilitators, then we'll rearrange as needed. But the goal is that you take about 30 minutes, that your facilitator will write down on the large Post-it note there what your observations, the barriers that you describe, and we're going to ask those facilitators then, I'll break the room from discussion in about 30 minutes, and we'll ask the facilitators to talk back to Harold and Mylea and myself about what your findings are. Thank you. You stay there.